What I do love is listening to Joseph, is actually to see how close our practices are together. And what was very nice for me is listening to Joseph and seeing that we're all really thinking along the same lines. And I really enjoyed his talk. So, short bowel syndrome. I'm not going to pretend to you I'm an expert, but I look after a lot of babies who have short bowel, mainly because of surgery. So I'm going to give you a bit of an overview of short bowel, and just some of the things that that I think are important to know about, or that I've gleaned I think are important to know about, and it may help in our practice with these babies who are really quite challenging. So yes, that's my hospital. I'm going to talk about background pathophysiology and management. I mean, essentially we're talking about a malabsorptive disorder caused by often the surgical removal of significant length of the small intestine, or rarely a complete dysfunction of the intestine. Usually more than 2/3 of the bowel needs to be lost before you get any symptomatology, and I'll come back to that in a second as what that means. And of course, the malabsorption, you're talking about macro and micronutrients, which are because the absorption is very, very important coming through the intestine, looking after over 90% of our requirements coming in through that way. So it can be congenital or acquired, as I say, 1/2 to 2/3 of your intestine. And so what we're really talking about is intestinal failure, but perhaps we can talk a little bit more in detail. What we say is you cannot digest or absorb nutrients and fluids and electrolytes essential to live and grow and develop normally. So anatomical or surgical NEC, or occasionally functional. I've never seen microvillus inclusion disease, which means your gut doesn't work at all. Maybe some of you have. But we'll all have probably seen it for a different reason. In the NICU, I see it because of NIC and gut resection, sometimes a congenital anomaly, sometimes, very, very occasionally, villus disease. So, symptomatology. It's highly dependent on the physiology of the remaining small intestine. So the symptoms will differ depending on which bit of the intestine is missing or compromised. So you can have diarrhea, steatorrhea, failure to thrive, fluid and electrolyte loss, abdominal pain, bloating, a number of things that can manifest, and they all manifest slightly differently. You can look at specific malabsorptions of becoming vitamin deficient or mineral deficient, and sometimes there will simply be clinical signs. So, what's the pathophysiology? I think let's start with the jejunum. The jejunum is relatively important, but interestingly probably not as important as the ileum. It is the primary digestive site for most nutrients. It has long villi. It has a large absorptive surface. And therefore you get a high concentration of digestive enzymes and transport carrier proteins. So that's the jejunum. But the jejunum, believe it or not, is a very leaky organ itself. So the jejunum absorbs, but also leaks back into the lumen. And you get rapid movement of water and electrolytes through the mucosa, and actually comes from the plasma to the lumen to dilute contents. So the jejunum often is sucking water in because it's a very leaky part of the gut. And if you have a hypertonic feed, that's where the water is drawn in from, into the jejunum. It's drawn in from the plasma. And that's very different from the ileum. So the adaptation of the jejunum is limited. So if you're just left with some jejunum, you'll see in a minute why you probably have a bit more of a problem than as if you're left with ileum. Because the ileum adapts both in structure and function to increase absorption, but jejunal adaptation is very, very limited. The ileum has shorter villi. It has a far, far smaller surface area compared to the jejunum. So most of the fluid is actually resorbed in the ileum, and to a lesser degree on the colon. And if a substantial part of the ileum is resected, you will lose fluids, electrolytes, and B12. Remember, if you have a bile acid problem, and short bowel syndrome does not necessarily mean you have a bile acid problem. But if bile acids are an issue and they reach the colon, then you will also get a secretory diarrhea. So it's a double problem if you have that as well. So we know the absorption, it specifically absorbs vitamin B, B12 and the bile acids, so very important there. And in adult data, and unfortunately it's mostly adult data that we have on this situation, there's very little good data in the neonate, a little bit in children of course, but not in the neonate. And you're looking at greater than a loss of 60 centimeters in an adult, they can become vitamin B12 deficient. More than 100 centimeters, you can become bile salt and fat deficient and get fat malabsorption. But the length in infants of loss isn't actually very well defined, and it's often based on what a surgeon sees or a surgeon measures or a surgeon tells you if there's been a laparotomy. So this secretory diarrhea can be a problem, and of course one of the other issues with this is you get hyperabsorption of oxalate in the colon, and so more important in children is that you can get hyperoxaluria and kidney stones if you take certain types of food. So the ileum is very good, it's adaptable, it has significant growth in length, diameter and function, although it's gradually, and there is genetic variation. So the ileum is a remarkable organ in that that is the one that adapts. And I'm sure many of you will have stories of a baby who's returned from surgery and they just have a few centimeters of ileum left and there's very little else. And then 6 months later, for whatever reason, with adhesions or they're opened up, and all of a sudden there's a massive gut that seems to have appeared from nowhere. The ileum really does regenerate and grow. And because of that, you never quite know how things are going to end up with your baby. Now we also know that the ileocecal valve would be an important area too. It stops the colonic material refluxing into the ileum, and that's pretty important. It does regulate the passage of fluid and nutrients, and the loss of the IC valve, really the only thing you can say from trials and studies is that if you lose your valve, the ileocecal valve, then ordinarily your recovery is longer. It's statistically associated with a longer time on parenteral nutrition. So infants with less than 30 centimeters of small intestine and the loss of the IC valve are unlikely to be weaned off PN. It was a study back in 1991. So it significantly affects your ability to be able to feed independently. So without your ileocecal valve, you'll get bacterial overgrowth as there's more reflux from the colon, progressive dilatation and decreased motility, malabsorption, bowel inflammation, and sometimes endotoxemia, liver injury, and lactic acidosis. So it's not good to lose that valve. Moving down through into the colon, we all know that it's very good at absorbing water, electrolytes, and also short-chain fatty acids. It slows down the intestinal transit. So if you don't have your colon, unfortunately, your transit time is going to be very much increased. As we know, transit time in our prem babies is much slower, but if you lose your colon, then transit time is very fast indeed. Ordinarily, once again, there's some adult data that says the presence of about half your colon is equivalent to about 50 centimeters of small intestine and can predict your success from weaning. In children, there's inconsistent conclusions as a predictor of weaning with the colon, and the colon is thought to be a bit less important than in the adults. That's simply because it's difficult to predict when the colon is resected. So intestinal adaptation, you're less likely to adapt well if your small intestine length in a baby is less than 15 centimeters. If you've lost your IC valve, if you've had a colonic resection or more than 50% of the colon was resected. Also, if you didn't get a primary anastomosis, that is also a very poor sign as well, that you need to be reconnected later on. So all this can tell you really is that you have problems. Now 15 centimeters seems absolutely tiny when a baby is born with over a couple of hundred at term, but amazingly that 15 centimeters in 6 months' time can be 60 or 70 or 80 centimeters, because the ileum really does adapt. And that's what's impressive. So the adaptation depends on the exposure to luminal nutrients. Now we've just heard from Joe about how important it is to enterally feed. Let me tell you, in short bowel syndrome, it is absolutely vital to enterally feed. That's the only way a child is going to get better, or at least attempt some recovery. So because you have the enterocyte-derived mediators, glucagon-like peptide, growth factors, and it's most important in the few months after resection. So a bit like the question I asked Joe, is it better to give or hold? And his answer, quite rightly, and I'm glad he said it, was it's better to give, which is what I do and we do, although I worry about giving cow's milk because it is so the wrong thing to give. But in this short bowel syndrome, the sooner you can get some milk into that intestine, the better the baby is going to do, no matter how difficult. And that's very interesting. So moving on to a bit of the management. You want to maintain nutritional stability. That sounds easy, doesn't it? But that's the hard bit. Your gut needs to adapt. It needs to grow longer. That takes time. It needs the increased ability to absorb nutrients. And that's with length and maturity. And then you use nutritional support. And I'm going to give you an interesting study a little bit about neocate during adaptation, because this is when we do talk a bit more specific about the types of milks if we don't have human milk, which of course we want all the time. So the cornerstone of management, the adaptation is enteral nutrition. Enteral nutrition is what you have to have. There's nothing else you can do, because it stimulates function, it stimulates the hormones, the biliary secretions, and the pancreatic secretions. And all of that will give you a far, far better mucosal adaptation. And that's what we need to keep in the back of our mind. So regardless of the length, where the surgeon comes out, I had a baby came back the other day where the surgeon said, I don't think I can even measure it. It might be 3 centimeters. Horrific. I mean, horrific thought where everybody, oh my goodness, what a complete disaster. Regardless of the length, you've got to feed. You've got to give, even if it's only a few mils. It's nothing to do with energy. And eventually, of course, if a baby can suck, it can avoid feeding aversion, which is the last thing you want in somebody who you desperately need to enterally feed. So somehow you've got to get something in. It will not occur if there is total reliance on parenteral nutrition. No matter how good we are at recipes and how much we love it, we have got to put something in the gut. So, early, slow, ideally breast milk, but when we don't have it, we use either amino acid formulae or extensively hydrolyzed formulae. And I'll come to take a little bit more about that. So protein, carbohydrate and fat, absolutely essential for these infants. The biggest problem that I didn't probably fully appreciate is that short bowel syndrome, the biggest risk is actually for the protein allergy. That's the big sensitivity to the gut. Yes, of course, the length is a problem, but in fact, the protein allergy is a massive risk to these babies. So you want breast milk. Wonderful, wonderful breast milk. I want as much as we can get it. But what if you can't? Well, the reason these formulae are not because it's easily absorbed and better for the baby, it's actually because of the hypoallergenicity of the formulae themselves. Osmolarity, well, it's not such an issue, because it's not going to have a great effect, because there is obviously not a great deal of gut that you're talking about, and if the jejunum has been removed, the osmolarity has a less effect on the ileum. However, we use progestamine and nutramigen. ordinarily first before neocate, because neocate does have a slightly more osmolarity, and therefore it's taken into account, but it's not the biggest issue. And obviously in older children you would use intact protein if possible. So this is a study, amino acid versus extensively hydrolyzed formula in short bowel syndrome. The aim is to assess the impact of amino acid on enteral feeding tolerance and parenteral nutrition requirements in children with severe short bowel syndrome. It's only 4 patients because there's not a huge amount of studies, but this is quite interesting. These, from 23 months to 4.75 years, kids with short bowel syndrome on long-term PN, initially all were on an extensively hydrolyzed formula because that's what they were taking. And what they decided to do was assess them before and after they converted them all to an amino acid formula and followed them up at about 48 months. So you had children, all these children were on extensively hydrolyzed formulae, and then they were all monitored, and then switched to amino acid formulae. And feeding tolerance, nutritional status, stool analysis, colonoscopy and biopsies, disaccharide levels, intestinal permeability was all reviewed. So all patients ceased their parenteral nutrition within 15 months of starting the amino acid formula. They had a decrease in stool output and a resolution of vomiting. They had a decreased number of hospitalizations than they were having. They had a decreased number of septic episodes, proven versus suspected. They had fewer central line insertions. There were decreased intestinal permeability to lactulose. They had higher disaccharide levels. So the change and the conclusion from this simple observational study was that an amino acid-based complete infant formula can actually improve feeding tolerance and eliminate the need for parenteral nutrition. Now you might say these children were getting older anyway and the gut was getting more mature, but they were just on extensively hydrolyzed formula and seemingly going nowhere until that formula was switched to an amino acid formula. So what about carbohydrate? Carbohydrate's quite interesting because it depends on the proximal small intestine. Lactose restriction is not typically needed. I don't know whether in your practice, but I have an awful lot of people still talk about, oh, you've got to stop the lactose, lactose is dreadful, lactose intolerance. I mean, let's be realistic. Human milk is 100% lactose, and we don't restrict human milk, we want it. But when it comes to formulae, we always seem to want lactose-free. In my head, I'm never quite sure why that should be the case. And in fact, there's no evidence that that is required at all in these children. They do not need, ordinarily, a lactose-free formulae. However, many formulae are made lactose-free in the belief that that is what is required, but not necessarily in this syndrome. Complex carbohydrates are better, and as I said earlier, high oxalates are a problem. Not that we're going to have spinach and rhubarb problems in our babies, but as you get older, that is a type of food that needs to be absorbed. Fat is interesting too, because you can have MCT neocate or you can have neocate. Which is better? Well, MCT is easier absorbed, but actually it's a higher osmotic load and actually provides lower energy. So is that the right thing to do? And the answer is probably not, because typically in short bowel syndrome, as I've said earlier, there's normal pancreatic and biliary and lymphatic functions. And there's no need to provide MCT milk and change the osmolarity and reduce the energy requirement. They need long chain fats. So what about the frequency? This was similar to what was said earlier on. Most of us will bolus feed our children, and most of us will bolus feed these babies, and we tend to give them continuous feeds ordinarily because that's what a surgeon often says, is put the child on continuous feeds. That seems to be what the surgeon says to us, but we have no reason to believe that's better for the baby, and in fact the evidence is whatever the baby tolerates. So the vast majority of our babies get bolus feeds, some will go on to continuous feeds if we have problems with bolus feeds, or we may have a gastrostomy and we're giving some continuous feeds that way because it's easier, or there is a tolerability problem. But ordinarily, we don't know which is best. But there's appears no harm in each from our nursing perspective, and what the gut is more normal is more normal for the gut is the bolus. So we would bolus feed our children, and obviously we need to maximise the feeding tolerance and clearly improve the absorption lipids and obviously the protein, because that's what we want to try and do. We want to constantly saturate the carrier transport proteins. We need to take as much advantage of the absorptive surface area as possible, and this enhances adaptation. So very frequent bolus feeding or continuous feeding is what you need to do. Later on, small frequent feedings are preferable to infrequent large feedings. So we very rarely get to large feedings with these infants. Most of them continue to take small and regular, and that tends to be the best way for the gut to adapt. So what about tapering of the parenteral nutrition? Well, really, once again, we've heard about how people do that, but in short bowel syndrome, because you've got such a slow advancement of the enteral feeding, then you've got a very slow tapering of your parenteral nutrition. So when you stop is quite important, because if you stop at 80 or 100 mils per kilo, you may not get higher for many days or even weeks and sometimes months. So stopping parenteral nutrition is just something that needs to be thought at. It's not as simple as stopping it in a premature baby who's now tolerating full feeds. So, and we know we want our enteral feeding to get more energy, and therefore we can only turn off the parenteral nutrition when we feel the baby is getting enough enterally. So once again, as I said, frequent small increases. Now, whether you do them every 3 days, 5 days, 7 days, it really depends on the baby or the child. You've got to try and test the child to increase the enteral feed in the back of your mind, knowing that enteral feed is what the baby requires. So you keep testing, and sometimes you go forward and back a bit, forward 2, back 1. It's something that you just need to advance, and you'll find out how much a baby can tolerate. And as time goes on, they should, in theory, in the first few months, as that gut grows, be able to tolerate a little bit more and a little bit more. So what about the correlates to the clinical outcomes? Well, this study was looking to determine the clinical outcomes in patients with short bowel syndrome, a retrospective medical record review from 86 to 98. Neonates with short bowel syndrome dependent on parenteral nutrition for about 90 days, and it was congenital or acquired. They looked at 30 patients, 43% of them had NEC and 57% had intestinal malformations, and the mean residual small intestine was about 83 centimeters, not a bad length. And the factors really that are associated with a shorter duration of parenteral nutrition really haven't changed over the years. Enteral feeding with breast milk or an amino acid formula, number 1. Number 2, the more gut you've got left, the quicker you'll come off the parenteral nutrition. It's not rocket science. But what's interesting is the percentage of calories received enterally at 6 weeks after surgery is an indicator of how quickly you'll be able to come off your parenteral nutrition. Once again, emphasizing this early feeding, day 1 in fact, of trying to put something into that gut, if you can, and even if it's trophic or very, very little energy. Because the bigger percent of calories received enterally, then you have a shorter duration of PN. That's no different than the data that actually says the higher volume of breast milk you get in a preterm infant in the first week of life, then the less likely the baby's going to get NEC. A lot of data related to the amount of milk that goes into the gut. The presence of an intact ileocecal valve and the frequency of catheter-related infections were not significantly correlated with the duration of PN in this study, so perhaps less emphasis on that there. Now, unfortunately, if you lose your IC valve, you can get short bowel bacterial overgrowth. What do we do about this? Well, These are various courses of rotating broad-spectrum oral antibiotics. And these are given not necessarily with positive bacterial cultures, but looking at tolerance of feeding, looking at gut distension, just looking at a baby's condition. And some people will rotate metronidazole, others cotrimoxazole, oral gentamicin, sometimes penicillins and cephalosporins, and ordinarily prophylactic antifungals are given while babies are on antibiotics. So bacterial overgrowth is something that's a problem. And there's no right drug or combination to use. These are all quoted in the literature as being okay. Ordinarily, we use metronidazole, and recently we used some oral gentamicin, in fact oral vancomycin as well, in one of our infants. You often find some of these children, the surgeons love H2 blockers, and almost any baby that seems to come back from surgery is an H2 blocker. If they're premature, I normally stop it very quickly, because our surgeons are pediatric surgeons and not neonatally trained, and they don't know the data of the concerns we have with H2 blockers and infection. But often you'll find H2 blockers in our older children may be in use, PPIs, octreotide, cholestyramine sometimes if you're having problem with your bile acids, and iron supplementation, of course. So these are typical medications that are used in short bowel syndrome depending on requirement. So what about the future? How can we look after these babies better? Well, I suppose the first thing is to try and, in an NICU, is to try and reduce NEC and the need for bowel resection. And if we could reduce NEC, that would be fantastic. And I think really the only thing that I go on and on about in my unit is actually trying to get more and more breast milk for my infants rather than using formula. Fish oils are interesting, and as Joe said, SMOF isn't common, has only recently been introduced into the United States. We're very lucky in Europe. We often get things many, many years before the USA when it comes to feeding. When it comes to feeding innovation, new formulae, new types of innovation, normally about 5 years before the USA they come into Europe, and are often developed usually in Holland or Denmark and Germany. And so we're very, very lucky. So we've known SMOF since 2006, 5, 6, 7, whereas it's only now just coming to the USA many, many years later. And so they're just beginning to use it. So fish oil you'll see in the literature, but in actual fact for fish oil in lipid, that's pretty routine for many of us outside the US. Growth factors, can we find growth factors to help stimulate the ileum to grow? There's research there. Probiotics, gosh, we could talk for another hour or so on probiotics, couldn't we? Do you use them? Don't you use them? How useful are they in short bowel syndrome? Well, possibly, and some people will use them. The question is which one? How long for? What's the dose? The usual questions about probiotics. And of course, bowel transplant. There are bowel transplants, and are my babies in the UAE, should they fit the criteria for a bowel transplant, do get sent to the UK for assessment to see if they are okay for bowel transplant. But that's quite tight parameters. It's very difficult surgery, and it really isn't for everyone. So there's perhaps a little bit of hope. It's going to get a bit better in the future, but I think if we reduce NEC and prevent the problem in the first, then that'll be a great help. So short bowel syndrome is a malabsorptive disorder. It really depends on the length of your small intestine, usually the ileum, far more important than the jejunum, the ileocecal valve, and the colon. Jejunum important, but ileum certainly adapts better. So what can we do? Enteral feed early and slowly, beware of allergy, breast milk, amino acid formulae, and extensively hydrolyzed formulae is really all we have in our armory. I don't know of anything else that has changed practice over the years, and that's certainly how we would try and look after these babies. Thanks very much indeed.
Questions? Thank you very much, Julian. And the floor is open for a few questions.
Young man.
Is there any young man? Thank you. Is there any role for motility hindering drug like Imodium? And are you aware of intestinal lengthening technique, the spiral incisions and?
Yes. So first question. Yes, we do. Yes, I didn't mention it there. It's a good point. We do use loperamide actually, and loperamide in doses that can be quite large. So some of my babies usually the babies who have an ileostomy, who've yet to be joined up, we try and get our surgeons to join them up quicker because we might have horrendous ileostomy losses. So in those babies we are using a lot of loperamide just so that we can keep a certain amount of breast milk going through. We will use loperamide to stop the massive secretory losses that you can get. Usually once a baby's joined up, it's much less of a problem. So usually our babies with ostomy, yes, we use loperamide, and we'll go quite high on the doses. The second question was intestinal lengthening. My understanding is that it's not great and that it doesn't work and it's not routinely advocated. You may know more than me, but it's not something that we do or we send to our surgeons or I've seen done. I've heard about it. My understanding is that it doesn't work, but is there a program anywhere here, or does anybody know more? I don't know, but we don't use it.
If the baby is having a double-barrel stoma, do you collect the fluid and inject it in the other one?
Yes, we do. Yes, we do. Yes, we do. Yes. So the question there was if you've got a open-ended stoma and fluid comes out one, and you put it back in through the other. Yes, we do that. Really, that's just depending on the length of time the baby's on the antibiotic. So it's just to cover the antibiotic, the broad-spectrum antibiotic going into the gut, in case you get candida overgrowth. So really, it's just the same length of time as the antibiotic. I think it's often stopped for 24 or 48 hours after. Yeah.
Do you get it on a daily basis or twice a week?
No, it's daily. Daily. Anyone hungry?
Other questions?
Okay, so it's been a wonderful day. I think we are all full from the amount of information that we received. I really want to thank the organizers of the conference, Dr. Hisham Awad for inviting me, Dr. Safa, Dr. Rania, Dr. Ghada. It's a great pleasure to be here. I learned a lot. Excellent program, excellent speaker.